So, Assalamualaikum and good morning. My name is Dr. Erin M. Ramli. I'm from Radiology HKL. So the topic of our CME today is spine radiography and CT. And I will be focusing on radiograph and CT in the setting of trauma, yeah, because you guys are in ED, selalunya kita tengok all the trauma case kan, most of the time. All right. So first up, we'll have to know the anatomy, which is the vertebral column. So it consists of 33 vertebrae. So you have 7 cervical, 12 thoracic, 5 lumbar. Sacral and coccyx are fused. So you have 5 sacrum and 4 coccyx vertebra. So in fetus spine, it's a smooth C shape in flex position. And those are referred as primary curvature. All right. Okay. So in adult, the primary curvature is retained at the thoracic and also at the sacrococcyx region. And that one we known as the kyphosis. Secondary curvature is caused by the extension of the cervical and also the lumbar. So that's why we have the lordosis. Now we know in that. All right. A typical vertebra, we have anteriorly the vertebral body here. Posteriorly, we have the neural arch, which consists of the pedicles and the lamina. And the pedicles, you have the superior and inferior notch, hence adjoining pedicles from the intervertebral foramen, and they transmit segmental nerves. And you have the transverse processes on each side, which is at the junction of the pedicle and lamina and extends more laterally. All right. So you have the spinous process posteriorly, which is the fusion of the lamina. Articular process, which projects superior and inferior from each lamina. So this is a superior articular facet, which face more posteriorly, and inferior articular facet, which face more anteriorly. And you have the pars interarticularis, which is between the superior and inferior articular facet. Am I going too fast, or you guys are okay? Okay. Okay, yeah. All right. So this is just a recap. So now we first go to cervical vertebra. So the typical features of cervical vertebra, you have the foramen transversarium. Yang lain memang tak ada. So it's within the transverse process and it transmits vertebral artery except for C7 yang tak ada vertebral artery dalam foramen transversarium. And also they transmit the accompanying veins and the sympathetic nerves. And the transverse process have anterior and posterior tubercles. So 1, 2, belakang, depan belakang. All right. And what's interesting about cervical vertebra, you have uncinate process, which is a small lips on the posterolateral side of the superior surface of the vertebral bodies. We're going to see the examples later. And it's usually you can be seen on C3 to C7 vertebra. And it's not a true synovial joint. It forms the ancovertebral joint. The ancovertebral joint is not a true synovial joint. So it's actually due to degenerative of the disc. And spinous process in the cervical vertebra are bifid, small bifid, okay, which ada dua projection macam tu, bifid process. And articular facets are relatively more horizontal, and you have a triangular shaped spinal canal. Okay, first we go to C1, which is also called atlas. Atlas doesn't have a body, and you have lateral mass on each side. And the superior articular facet articulates with the occipital condyle here, which forms the atlanto-occipital joint. So in our report, we can say you will always see atlanto-occipital joint is normal and everything. So these are the atlanto-occipital joint. And the inferior articular facet articulates with the axis, which forms the atlanto-axial joint, which is on the lateral side, right? So you have the anterior arch and you have also the posterior arch. So the anterior arch are the tubercle on the anterior surface and facet posteriorly, which articulates with the odontoid process. So these are the facet which articulates and forms the median atlanto-axial joint. So this is the joint which we call the median atlanto-axial joint. And posterior facet, posterior arch is the groove behind the lateral mass for vertebral arteries. All right, and then you have C2, you have the odontoid process of C2. C2 is also called axis and represents the body of the atlas. It bears no weight, so dens memang tak pegang apa-apa bebanan daripada skull, ya. So dense ni memang dia bears no weight and it slopes articular surface on each side. It forms the median atlantoaxial joint with the atlas as well. They also have lateral mass and transmit the weight of the skull. So the weight of the skull rests on the lateral mass here. And what's important, C7 vertebra, which also called the vertebra prominence. You don't have the bifid spine, but you have a long palpable spine. If you feel on your tengkuk pun, you can feel the C7 vertebra yourself. And the foramen transversarium is actually sometimes small or sometimes absent and usually transmit only the vertebral veins. And the anterior tubercle of the transverse is relatively small, so kecil saja compared to the rest of the cervical vertebra. All right, so since we are talking about radiograph and CT, so spine radiograph, which are also, you guys selalu faham kan, radiograph are X-rays. So it's quick, easy, accessible, and less radiation compared to CT. So the common clinical indication as listed here, so most of the time pain, trauma, kan? Fall, MVA, sports injury, so any neurological symptoms. So others are like congenital abnormality, degenerative, inflammatory, or malignancy or metastasis. All right, so these are just terminology that we usually write down in our report. So spondylosis is general term for degenerative changes of the spine. Okay, spondylolysis is more of usually fracture of the pars interarticularis. Spondylolisthesis, usually when we, it's the progression of the spondylosis. So it refers to the displacement yang kita panggil slip disc. So displacement of one vertebra over another. Bila dia ada itis yang bawah, spondylitis or spondylodiscitis is usually inflammation infection. Spondylitis is the inflammation of the vertebral body. Spondylodiscitis when it involves the intervertebral disc as well. So all this we can see on the end plates. You have the spondylodiscitis on radiograph, tapi most of the time is MRI diagnosis lah. All right, so these slides is actually showing you the positioning of the radiograph, the spine radiograph. So on your most on the left hand side, so you can see these are the lumbar spine, so on lateral, AP, and also obliques. These are how they are positioned. Okay, in the middle you have the cervical, so this is AP, lateral, and these are open mouth view. All right, so on your most right hand side, these are the thoracic vertebra radiograph. So this is positioning. I have to rotate it, so kena pusing kepala sikit lah, tengok. All right, so yeah, I'm sure you guys are very familiar with this form. So this is my department form, Borang Pemeriksaan Radiology. So usually you guys are going to fill it, very good, very nice. But sometimes people overlook this part, which is the dose for all of the CT as well as radiographs. Okay, now CT imaging of the spine. It's an examination of choice for bony structures. So indications, usually trauma, bony degenerative changes, and sometimes for patients who cannot have MRI. So the disadvantages, high radiation dose and artifacts or any movements or strict artifacts from implant or any materials. So memang akan dapatkan artifact lah. So the image quality is basically what my radiographers will try to do it, so make it very nice for you guys to see. Choice of imaging parameters, we have high KVs, MAs, and thin collimation and low pitch. So image post-processing, we can reconstruct the algorithm and reformat for a good view of the CT image, okay? So first we go to the cervical radiograph in AP view. So as you know, these are the checklists that you have to see. So these are just the basic checklists. What I want to show is the uncinate process here. So you guys can see there's a small lip here, like macam ada small projection up here. These are the uncinate processes which can be seen at C3 until C7. Yang vertebra lain tak ada. All right. So when looking and reviewing AP view of the cervical radiograph, not only you have to see the alignment, but try and look for all those things, any small fractures that can be seen. All right. So this is the lateral view of the cervical radiograph. You can see this is the anterior arch of C1, dens of C2, and the spinous processes as well as the vertebral bodies. So these are the pre-vertebral soft tissues that we need to see. Sometimes very subtle pre-vertebral soft tissue swelling. You can see here. So these are the first indicators of any small fractures. All right, this slide is the normal anatomy of the anterior vertebral line, or the lines that we need to see when reviewing the lateral radiograph. So you can see here, this is called the 4 lines. That's very important: anterior vertebral line, posterior vertebral line, spinolaminar line, and spinous process line or posterior spinous line. So these lines are actually need to be congruent or aligned with each other. So that's why when we say vertebral alignment is preserved, so these are the lines that we see. So if there's any disruption of this line or any step off, so that is the first indicator of fracture or any prevertebral hematoma. All right, so the prevertebral soft tissue is less than 7 mm at C2 and less than 22 mm at C6 vertebra. Right, open mouth view. This is the example of radiograph for open mouth view, which is usually for C1 and C2. All right, so you can see here, this is the posterior arch of C1. This is the lateral mass of C1, 1 and 2, and the odontoid process. So any fractures along here, we can definitely see it. All right, there's symmetrical distance between the lateral mass and also the dens of C2. All right, this is only the CT reconstruction on coronal view, which shows a similar AP view of the cervical spine. So you can see the alignment. There's no step off between the lateral mass and also the lateral mass of C1 and the body of C2. This is the sagittal reconstruction. You can see dens, anterior arch. So basically the lateral view of the radiograph. All right. Okay, this is axial view of the CT, which is taken at the level of C1 vertebra. So this is actually showing how C1 will look like on CT. So this is the anterior arch, posterior arch, spinous process is small. All right, so this is the odontoid process, and that's the median atlantoaxial joint, lateral mass, and the foramen transversarium. All right, first we go to the C1 fracture, which is also called the Jefferson fracture. This is a compression fracture of bony ring of C1 and characterized by lateral mass splitting and transverse ligament tear. So behind dens of C2, you have the transverse ligament, which holds the C2, the dens of C2 on its place. And the mechanism, axial blow to the vertex. Imagine diving injury, when you dive and you hit something like a rock ke apa dekat dalam air, and then you get the blow to the vertex. So radiographic feature, if you're taking a radiograph, open mouth view, which shows the displacement of the lateral mass of C1 beyond the margins of C2. Right, so this is an example of Jefferson's fracture. So transverse ligament is actually holding here. So when there is widening of the atlantoaxial joint and also the median atlantoaxial joint here, so that's indicative of fracture already. Okay, it's also called a burst fracture. So on this, you can see the lateral displacement of the lateral mass of C1, which overhangs beyond the body of C2, and the distance or the space between the each side of the odontoid process is also widened from here to here and here to here, and then you have a step off here. Okay, so that's Jefferson's fracture for you. Okay, this is on CT. So tak kisahlah dia akan patah ke sini ke, asalkan the bony ring depan belakang, ya. CT is actually indicative or required to see the extent of the fracture and the presence of bony fracture within the spinal canal. All right. Next, we go to Hangman fracture, which is a C2 fracture. It's a fracture involving the bilateral pars interarticularis of C2, and it's, as it names, it is caused by hyperextension, example in hanging. And if it's an MVA, the chin hits the dashboard in the MVA. Okay, radiographic feature, lateral view, prevertebral soft tissue swelling, and avulsion of the anterior inferior corner of C2 associated with the rupture of the anterior longitudinal ligament. So your anterior vertebral line is already disrupted, and you have anterior dislocation of C2 vertebral body and bilateral pars fracture. So you have pars fracture here. You imagine like that. So you have the fracture over here. So ini on axial, ini on lateral views. So you can see fracture here. So more example, you can see there's a step off here. So ini sudah tak align, right? So you have a fracture here. Okay, this one is very subtle, but you see a fracture here. But you can see there's the alignment is already disrupted. So when you draw a line, tiba-tiba tak sambung kan? So dia macam ada step off dekat situ. So at this region, the prevertebral soft tissue is already widened. All right. So this is Hangman's fracture. So again, Hangman's fracture on CT. Another example of Hangman's fracture. It can go anywhere. So as long as the pars interarticularis is disrupted. All right. Next one is odontoid process fracture of C2. So it's best seen on lateral view, and it should be suspected if there is an anterior tilt of the odontoid process on lateral view. Kalau nampak on lateral view tu, tiba-tiba lari sikit the odontoid process, then you should suspect a fracture. Okay. It's better delineated on CT, sometimes only prevertebral soft tissue swelling. All right. Not necessarily. So if you guys have any suspicion of a prevertebral soft tissue swelling, by all means. If it's a trauma, by all means. We never say no to trauma. All right. Odontoid fracture classification, type 1. You have 3 types, type 1, 2, and 3. Type 1 is potentially unstable. Imagine there's a fracture of the tip, because it's a fracture of the tip of the odontoid process. So it can go anywhere. So it's potentially unstable. Type 2 is the base. It's unstable at the risk of non-union. And type 3 is the best prognosis for healing, because sometimes it's more lagi dekat, so it's easier for healing lah. All right. Okay, so this is type 1 odontoid fractures. You can see on open mouth view, that's the fracture line. This is the tip, that's the fracture. Okay, this is a dense. This is just showing you on CT, sagittal view. All right. This is type 2 odontoid fracture, which is at the base of the odontoid process, here on lateral radiograph, and this is on open mouth view. Okay, again, type 2 fracture on CT. And this is, looks like type 2, bila buat CT, dia type 3, right? Sebab it's already extending into the body of axis. So on radiograph, you nampak macam dekat base saja. But when you request for CT, dia extend. The fracture already extended into the body. So we upgraded it into type 3 already, okay? Right, next we go to flexion teardrop fracture. So this is an unstable fracture. So you have a posterior ligament disruption. So imagine this is the posterior ligament. So this is the anterior longitudinal ligament, posterior longitudinal ligament, and that's the spinal canal. All right. So this disruption of the posterior longitudinal ligament here, and anterior compression fracture from a severe flexion injury. So diving in shallow water. So hyperflex and compress. Okay. So best seen on lateral. So these are the teardrop ligament. You can see a prevertebral soft tissue swelling. Ada disruption of the ALL, tiba-tiba lari macam tu. And you have one bony fragment here, anterior to the vertebral body. Posteriorly, the vertebral body macam sublux into the spinal canal. And as you know, when there is subluxation posteriorly, so you have the spinal cord compression. And sometimes you have the spinous process fracture also. All right. So again, this is a teardrop. You can see here, there's disruption here. Tiba-tiba ke sini, patutnya ke sini kan? So it goes all the way to the back and causing spinal canal compression. So and yet you have this anterior vertebral body fragment anteriorly. So that's the flexion teardrop fracture. This is on CT. Again, similar small teardrop fracture there. And you have the widening of the spinous process at the back. All right. Next, you have bilateral facet dislocation. So it's a complete anterior dislocation of the vertebral body resulting from extreme hypoflexion injury. So associated with high risk of cord damage, and the mechanism is extreme flexion of the head and neck without axial compression. So best seen on lateral view, there's a complete anterior dislocation of the affected vertebral body by half or more. So bilateral compared to unilateral, bilateral facet dislocation usually more than or half of the vertebral body yang the other side. So you can see one, this is more than the vertebral body superiorly. Okay, so disruption of the anterior longitudinal ligament, also the ligaments yang dekat belakang. So semua lari-lari dekat belakang ni, lines all semua lari. And you have the bow tie or bat wing appearance of the lock facet. It's very unstable. All right, so I'll show you what is the meaning of bat wing or bow tie appearance. So again, you can see here, try and trace it. Tiba-tiba dia lari ke belakang sini. Ni kan, sini tiba-tiba step ke belakang, right? So you have one here. So that's the bow tie for you. So on CT, it looks like that because dia dah lock, you cannot do anything about it. Patient pun tak boleh gerak dah. Okay. Right, so this is the CT reconstruction. Okay, this is lock. You imagine it's supposed to go satu macam tu. Tiba-tiba dia satu lari ke belakang. So yang ni tak boleh masuk ke depan lagi dah. It's already locked from here. Okay, and that's the axial view. This is called the hamburger sign, right? Reverse hamburger sign. Macam itulah. Alright, so this is the bow tie or bat wing sign. Okay, you can see here. Ni kan, dia dah macam jadi bat wing appearance. Okay, dia dah lock dekat situ, this one and this one. So macam a bow tie appearance or a bat wing appearance. Okay, this is the reverse hamburger sign or reverse hamburger sign. So when they are locked, so it becomes like a flip hamburger lah macam tu. Okay, by right it shouldn't be like that. It should be on the other side lah. Sepatutnya dia cantik je one after another. Alright, so this is unilateral facet dislocation. So kalau unilateral sebelah sahaja, it's simultaneous flexion and rotation. So only one sahaja yang dislocated. Similar findings, tapi you ada the discordant rotation above and below involved level, and you have the vertebral body affected is the dislocation of the vertebral body is less than half compared to bilateral. Okay, and you have widening of the intervertebral foramen on oblique view, as well as the bat wing or bow tie appearance. So it's more stable compared to bilateral facet dislocation. All right. So kalau macam ni, you can see it's less than 50% of the vertebral body, and you have the bow tie appearance. Right. So this is the anterolisthesis of C4 over C5, and you have the lock facet there. Okay, next one is clear shoveless fracture, also known as fracture of the spinous process of C6 until T1, usually C7. Okay, the mechanism is powerful hypoflexion combined with contraction of the paraspinous muscles, usually in shoveling lah. Orang zaman dulu-dulu kan kerja di shoveling kan, so dia ambil nama tu. Alright, so you can see just the fracture of the spinous process. So it's clear shoveless. Tak kisahlah kecil ke besar ke, it's still clear shoveless fracture. Alright, next we have the thoracic vertebra. We go from cervical vertebra into thoracic vertebra. So thoracic vertebra, you have costovertebral joints. Each thoracic vertebra ada full facet or two partial facets. You call the demifacets here. Okay, on each side, and accepts the head of a rib to form a costovertebral joint. So T1, complete facet superior, and demifacet inferior. T2 to T10, demifacet superior and inferior. T11, T12, single complete facet sahaja. Okay, again, you have also coastal transverse joints. The first 10 thoracic vertebra have facets, one on each transverse process, articulates with the tubercles of the ribs. Rib 11 and 12 articulates only at the coastal vertebral joints, and the spinous process are long and down sloping. Articular facets are relatively vertical. Sini All right, so these slides only showing you the anatomy, the normal anatomy of thoracic vertebra on AP and also lateral view. So these are the ones that we need to see on radiograph when reviewing the radiographs. All right, next we go lumbar vertebra, which are larger, stronger, and more square vertebral bodies. You have the mammillary process, right? These are the mammillary process, which is the prominence on the posterior aspects of the articular process. And you have the transverse processes. The upper forelumbar increase in size downwards. L5 is shorter but strong and pyramidal. Okay, and the articular facets are face each other in sagittal plane. Dia macam looking towards each other lah. Okay, and the spinous process is more horizontal compared to the thoracic vertebra, which is more down sloping. Okay, these are the radiographs on lumbar spine, on AP and lateral view. Okay, these radiographs are only showing you the normal anatomy. So the body, inferior articular process, superior articular process. Okay, so inferior, superior, and transverse process on the side. Kalau tengok on lateral view, transverse process on the side, pedicle, lamina, and also the spinous process at the back here. Right. Oblique view usually requested for lumbar vertebra. Ada juga cervical vertebra, but most of the time is lumbar vertebra. And it's basically to look for the pars interarticularis. Okay, so these are the pedicle, the lamina, and the facet joints, right? How to look for the pars interarticularis? So we have this sign which is called the Scotty dog sign. Okay, number 10 here is apa yang dia dah lorekkan ni is actually called the Scotty dog sign. So Scotty dog macam zaman dulu yang anjing warna hitam kecil-kecil tu is called the Scotty dog. So this is the Scotty dog sign. Okay, what you have to know, the number 1, which is this one, number 1 is actually the transverse process, which is the mouth of the dog. Number 2 is the pedicle, which is the head of the dog. Number 3 is the superior articular process, which is the ear of the dog. Number 4 ni yang kita nak tengok, which is the neck of the dog. Okay, bayangkan ini, sini yang akan patah selalunya lah kalau nak tengok pars interarticularis fracture, dekat sini lah yang patah yang kita nak tengok tu. So oblique view is to look for the fracture here, right? And number 5 is the body. Number 6 is the inferior articular process, is the front leg. 7 is the hind leg of the dog. Okay, 8 is just the interlaminar process. 9 is the intervertebral disc. All right. Okay, so these are pars fracture. You can see that's the neck of the dog. This is oblique view of the lumbar radiograph, the neck of the dog, and you have a loosened line here. Kat atas semua tak ada kan? So this is the fracture here. Again, there, the fracture there, there. All right. So you can see the pars fracture over there. Usually, kalau kita nampak, this is not oblique view, but on lateral view kita nampak dah. Alright, so usually bila kita nampak one ada a little bit of anterolysis, sometimes kita boleh macam maybe adalah macam tu. Okay, or sometimes can be degen also. Alright, so this is the pars fracture on CT. Okay, this is how it looked like on CT, sagittal, and axial view. Alright, when reviewing radiograph or CT, we basically our fractures we divided into 3 columns: anterior column, middle column, and posterior columns. So anterior column is anterior longitudinal ligament, and you have the anterior two-thirds of the vertebral body, middle column, posterior longitudinal ligament, and the posterior one-third of the vertebral body. And middle column, that's posterior column, you have the posterior elements, pedicle, lamina, spinous process, and the posterior ligaments all the way at the back. All right, so all our fractures are basically either single column, two column, three column, macam tu. All right, so first we go to compression fracture, which is a single column injury. All right, this is a wedge fracture, cortical break in the upper anterior wall, and there's loss of height and disruption of the vertebral end plate, mostly superior end plate. And then you can have a little bit of horizontal sclerotic bend, and the most important thing is the posterior cortex is intact. So this is how you differentiate this from burst fracture. Burst fracture, there's disruption of the posterior cortex. So compression fracture, posterior cortex is still intact. Okay, tengok sini posterior cortex intact, but you have reduction in the height and usually anterior superior end plate. Okay, dekat sini it's here, and you can see a little bit of disruption here. All right. Okay, again, posterior cortex intact. So this is the dense vertebral line, the discontinuity and the dense line on the anterior vertebral body. Right. Then we have the burst fracture. So again, as I said again, burst fracture, it's you have the retropulsion of the posterior superior vertebral fragment into the spinal canal. So you have the posterior cortex, which is already involved, and wedge compression fracture may bulge, but compression fracture may bulge but not displace posteriorly. Yeah, so itu yang differentiate it from the compression fracture. So you have sagittal fracture of vertebral body. Sometimes it can extend into the posterior elements, and widening of the interpedicular distance on radiograph, usually from fall of height and landing on the feet. So this is a two-column injury. Okay, so you have a little bit of retropulsion here on radiograph. One column, dah masuk two column kan, dah masuk ke belakang. So it's already two-column injury. And you have the widening of the interpedicular distance. Sini sama dengan yang sini, but this one is already disrupted. Again, these are also wedge fracture. This is compression fracture. Sorry, this is burst fracture. Okay, again, burst fracture involving the posterior elements. So not all the time, but sometimes you can have it. So ada orang kata kalau involve posterior elements, dia jadi chance fracture. No, chance fracture is different, right? Okay, this is chance fracture. Chance fracture is a horizontal fracture with separation of posterior elements. So it's a type of distraction fracture, which separation of or pulling apart of two adjacent vertebrae. And it's a severe injury, high chance of core injury. So it's a typical lap bulge injury. Maksudnya dia macam yang ada pakai belt dekat bawah aja, tak ada yang shoulder strap tu. So yang tu typical. So imagine if you have a fracture with only a lap bulge injury, so you akan pergi ke depan dan ke belakang. So you're being thrown forward, patah yang atas ni, and thrown backward. So patah yang sini pula. Okay, so you have a horizontal fracture with separation of the posterior elements. So if you have a separation of the posterior element, then that's only a chance fracture, which is called the distraction fracture. It's not kalau involve the three column, it's not chance fracture. Bukan semua yang involve three column adalah chance fracture. Okay, but chance fracture is three columns. All right, so again, fracture here, extending to the posterior element, and you have the separation of the posterior elements here. All right, and you can see here there's disruption of this. I mean, you have a lucency inside here. All right, this one also, next example, and this is only a coronal view of CT scan showing from anterior to posterior. Right, next we go to sacrum. Sacrum composed of 5 fused vertebrae, triangular in shape and concave anteriorly. You have the central and lateral mass, so central mass and lateral mass, and the sacral promontory, which is superior border of the central mass, which is the most anterior part of the sacrum, atas sekali. Okay, for anterior sacral foramina, 1, 2, 3, 4 on each side. And you have the ala of sacrum, upper anterior surface of the lateral mass here. Right. So the posterior part is called the median sacral crest, which is a fusion of spinous process, and it transmits either 4 posterior sacral foramina and posterior, and you have the sacral hiatus, which transmits the 5th sacral nerve. All right, so again, so these are the median sacral crest, which is fused, and you have the sacral hiatus, which transmit the 5th sacral nerve. So ni S1, S2, S3, S4, S5 keluar kat bawah. All right. Coccyx, you have 4 fused vertebrae into the triangular bone, and it's part of the pelvic floor. I'm not gonna go in detail of the coccyx because tak selalu kita nampak coccyx fracture kan, but sacral fracture memang selalu kan. So you can see these are all fused vertebra, right? Okay, common sacral fractures, common pelvic rim fractures, underdiagnosed most of the time and often associated with neurological compromise. Tapi in the setting of trauma, selalunya memang akan banyaklah sacral fractures, usually associated with other pelvic dissociation. Okay, diagnosis can be made with pelvic radiographs, but most frequently you require CT for further fracture configuration and characterization. So treatment, surgical, non-surgical, depending on fracture displacement, kalau ada open book, pelvic ring instability, and patient activity or demand. In young patients, often associated with high impact trauma, elderly usually fall. Okay, these are just the 2 types of fractures. Okay, here you can see the fracture here. This one's very nice. Okay, and this one here, there's a step there. Okay, so that's the fracture here. Again, on this time. Okay, and this one, you can see another fracture here. And you also see the symphysis pubis is already like macam ada diastasis. Okay. All right. So when we take a pelvic radiograph, so these are what we have to see in all, right? Okay. These are just transverse sacral fractures. You don't have to see, you don't have to know this. These are basically just a type of the sacral fractures. So let the radiologist lah by pening kepala nak cari apa type of fractures. All right. So this is on lateral radiograph. You can see the fracture here. Okay, so this is actually S4. Okay, on CT, these are the fractures. Fracture through the sacral here and into onto the inferior aspect of the sacral bone, and this one cross until into the sacral foramina. Right, that's it for today. Any question?
Do you have any questions from the floor? Announcements? Apa nak tanya Dr. Erin? Untuk daripada MA, pakar-pakar, any questions to Dr. Erin?
Hi, Dr. Erin.
Yes.
Thank you for a very good presentation. My question is about kalau trauma, spine trauma with progenic shock. So like CT scan is good for bone visualization, and then we also proceed with MRI for the visualization of the spinal cord. In your opinion, would MRI alone enough to cover both the bone and also the spinal cord?
In MRI, okay, you have to understand the situation in the setting of trauma. You want everything acute, you want everything fast, and dapat diagnosis sekarang, betul? Right. So, of course, in the setting of trauma, high impact trauma, we definitely go for CT, get a full picture of visualization first, and then if you need, of course, surgeons or any sometimes ED will request for MRI. MRI alone, looking for bone, we can see edema in the bone, but not necessarily we can see a tiny line fracture. Tak semestinya. Okay, CT is better seen for, is still better, superior in terms of bony configuration. For spinal cord, definitely if we see like burst fracture macam tu, if surgeon wants to go in, do something, definitely MRI is indicated, yes. But most of the time, in the setting of trauma, they would give steroid first, if I'm not mistaken, to reduce the swelling, and then go for surgery. So MRI tu dia macam kita tak apa, boleh withhold dulu macam tu. But yeah, of course MRI and CT, they both have their advantages, and MRI is longer. Patient yang tengah sakit-sakit sometimes tak boleh nak withstand that period of long duration. For CT, sometimes your patient is very unstable, so MRI is definitely not, especially in spinal shock, is definitely not your choice of imaging.
All right, thank you very much. Any other?
Dr. Erin, I just want to ask you one more question.
Yeah.
We do have some trauma patients who is still awake, and then patient is on cervical collar. So instead of sending for a CT because patient do not have neurology and everything, but just tenderness over the cervical region, so we apply cervical collar, so we do X-ray. So from the X-ray, when we discuss or we ask for a reporting, they're reported as a loss of lordosis. The term loss of lordosis means the patient has fracture or something else.
All right. So with regards to the report, there's always loss of lordosis. Usually my MO akan tulis loss of lordosis because dia tak nampak the normal lordosis, correct? Okay. But what sentence is after that? However, the vertebral alignment is preserved.
Okay.
Right? So loss of lordosis, when the patient is on collar, definitely there's going to be loss of lordosis, but you straighten the head, right? You straighten the neck. You don't want you want to immobilize. So that's where the loss of lordosis comes in the setting of trauma. But the sentence after that, however, the vertebral alignment is preserved, or vertebral alignment is preserved. So that means we're looking at the lines. We don't see any step deformity. We don't see any prevertebral soft tissue. Those are the ones that we conclude at the end. There's no evidence of cervical injury. Macam tu.
Okay.
All right?
Understood. Okay. Do you have any more questions from the floor? Okay, so far that do, and then we don't have any questions from online also. Okay, so I think in a nutshell, from experience, interpreting a spinal X-ray and CT can be very challenging.
Yes, agree.
I think the basic knowledge of anatomy of the spine is very important before you interpret X-ray and CT. And I think Dr. Erin has done a wonderful presentation today in depth about spinal X-ray and CT, and for that we thank you very much. I think if we have any further question, we will either call you directly or email you, if that's okay.
No problem, no problem.
Okay.
Thank you, Zalma. I have to say thank you to Zalma for trying to arrange the date again. I'm so sorry about the last session that there was a bit of misunderstanding. I was covering conference as well, so a lot of things happening at the same time, so we can't really distribute the job to other people. I'm so sorry. So thank you, Zalma, for trying to arrange this date today.
It's okay. So we hope to see you again.
All right, no problem.
Okay.
All right, thank you very much.
Thank you.
Thank you.